Hi, everyone. I think we can get started here. I think the beeps are beginning to slow down. So welcome to our lung map update and S1900E training webinar. I'm Mariah Norman, lung map project manager at SWOG Operations Office. We're very happy to hold this webinar and hear from all of you today. Just so you know, on the line from our study team, we have representatives from the lung map leadership, sub-study chairs, our statisticians, data coordinators, TM committee, site coordinators committee, our partners at the Foundation for NIH, and the SWOG Protocol and Operations Office, as well as I see some other team members who can also help answer questions during our Q&A sessions. As far as general housekeeping, as you see on your screen, if you're not already muted, please mute your line. If you're not speaking, there will be a Q&A session after we hear about the S1900E study and also at the end of the webinar. So as you come up with any questions, you can enter them into the chat box below, or at the time of the Q&A, you can raise your hand in WebEx using the little hand icon next to your name, and we'll unmute you. This meeting is recorded. We'll send out a memo notifying sites when the slides and the recording become available on the CPSU and SWOG websites. That'll likely be in a week or two. I should also mention, if you forgot to provide your CTEP institution ID in the registration form when you signed up for the webinar, and you'd like to receive training credit, you can email me at mnorman@swog.org. And we only need one research staff member from each site to receive that training credit. Okay. With that, I will hand it over to Dr. Roy Herbst, our lung map study chair, to give welcome remarks on behalf of the lung map team.
Thank you, Mariah, and thank you all for being here. I know how busy everyone is. First of all, I want to thank everyone for all they've done for our patients, for the lung map during the last year. It's been a very challenging time, but the protocols continued. Accrual has actually gone very well, and that's just a credit to all of you caring for our patients and keeping them safe. Today we have a very exciting task, 1900E. I was actually on a call earlier this morning where Kevin Shokot was there from UCSF, and it reminds me that it's about 6 or 7 years now since his seminal paper in Nature that showed that we could drug KRAS G12C by a very unique type of chemistry. KRAS is about 12 to 13% of the lung cancer patients we see, so it's a big piece of the pie. And today you're going to hear about a very interesting study where we, with LungMap, are bringing this drug to the clinic very quickly, really in record time to have this drug. The data for one of the other drugs in class were just presented this weekend at the triple meeting. We, of course, have known about the Amgen data for a while, and we're working with it today. But, you know, cancer is a genetic disease. So whether or not patients respond to this is going to depend on the other mutations, the genetic milieu of those patients. So that's what this trial is going to focus on. So today you're going to hear from Dr. Walker first, a little study update. Then you'll have the training by Suki and David, and we'll have plenty of time for questions. We'll hear about logistics. We'll hear from some tips from our site coordinator committee, overview of some publications from Mary, translational medicine overview from David, and then a general questions. I'm looking forward to this as much as you. And with that, I'll turn it now over to Saima to start with the update. But thank you. This is a team effort. So many people involved, and again, all helping our patients. So thank you, and thanks for being here today.
Thank you, Dr. Herbst. So I'd like to present a brief update on where we are with the LungMap study on behalf of the whole LungMap team. Next slide. So where are we now with LungMap? As you all know, the S1900 screening protocol initially opened up in June of 2014. This was a study which was designed specifically for squamous cell lung cancer to see if we could develop good, effective therapeutic options in the realm of targeted therapy for this disease. In January 28, 2019, the study actually closed when we expanded S1900 to other histologies of non-small cell lung cancer, as some of these biomarkers span across different histologies. On the initial protocol S1900, over a span of 5 years, 1,864 patients were registered. Since the new LungMap screening protocol opened for all histologies on January 28, 2019, we have had 760 sites up and running with LungMap central IRB approval, and we thank you all for your participation in this study. So far already in this short time span, 1,681 patients have been registered to this study. As you can see, several of these patients, 962 precisely, have been registered at the time of pre-screening while they're receiving their initial first-line therapy, whereas 719 patients were enrolled at screening at the time of progression. Within histologies, there's also been a shift, with most of the patients being enrolled to this new protocol having non-squamous histology. 1,144 of them are non-squamous, whereas 495 are squamous, and 42 patients have mixed histology. Out of these patients, 869 patients were actually assigned to a sub-study, either based on the molecular characteristics of their study or they were assigned to a non-match arm that they qualified for. Of these, 247 patients have registered for the study. In the next slide, I will review some of these available studies with you. So this shows the current LungMap schema. It looks a little complicated, but I'll try to simplify. On the left of the slide, we have the biomarker-driven sub-studies, and on the right side, we have the non-match sub-studies. The dark blue, the navy blue box, which is on the left side, shows the studies that have successfully completed accrual or closed because of the interim analyses, both for the biomarker-driven aspect as well as the non-match arm. Most of these studies were under the umbrella of the S1900 initial study for squamous cell carcinoma. Within the biomarker-driven sub-studies, we have S1900A, which was our first study for BRCA-positive patients with rucaparib. Second, S1900C is a study for STK11-positive patients with talazoparib in combination with avelumab. And S1900B is a study of RET fusion-positive patients where they receive LOXO-292, also known as selpercatinib. Then we have the exciting study S1900E, which you will be hearing about from Drs. Pata and Gerber shortly, with AMG 510. Within the non-match range, we have S1800A, which is a study of pembrolizumab in combination with ramucirumab compared to standard of care treatment. This is for immunotherapy refractory patients. And finally, there's a study which has been approved by the Drug Selection Committee, S1800D, which will be a replacement study for checkpoint inhibitor refractory patients that I will be mentioning soon. As I said, this study is open for all different histologies of non-small cell lung cancer, and each of these sub-studies operates independently from the others. And pre-screening can be performed while the patient is on any line of therapy for stage 4 disease. If any biopsy is needed in order to obtain tissue for the purpose of this study, that cost is paid for by our clinical trial. And if any of these biomarker-based sub-studies are successful, they may actually progress to go on to a phase 3 study if the endpoints are met and if it's feasible to do so, where the standard of care comparator arm will be based on what is the established standard of care at that time. Throughout S1900 and LungMap, we've seen a shift in what is considered to be the standard of care. So we all can guess what the standard of care will be at the time, we'll be opening one of these studies. Next slide. As far as the status of the current open sub-studies, so S1900A is our study of rucaparib for BRCA1/2 positive patients, which opened on January 28, 2019. This is temporarily closed for interim analysis. 64 patients have been enrolled, of which 27 are squamous and 37 are either non-squamous or have mixed histology. S1900C is a study of talazoparib with avelumab for patients with STK11 mutations. This opened also in January 2020, but is temporarily closed for interim analysis. Actually, it's open, but it's going to be closing on November 16th for interim analysis, and 37 patients have been enrolled of the accrual goal of 44 patients. S1900B is a study of LOXO-292 or selpercatinib for patients with RET fusion-positive non-small cell lung cancer. This study opened on February 10th, 2020. In the midst of COVID, 3 patients have been enrolled. As you all know, that selpercatinib received FDA approval this summer, and as a result of that, the study is potentially going to be redesigned, and we're exploring various options for that. As far as the non-match arm, the S1800A study is a study of ramucirumab in combination with pembrolizumab versus standard of care. This opened on May 17, 2019, and will be permanently closing on November 16, 2020 after completing accrual. 151 patients have been enrolled to this study. Next slide. So then we move to the sub-study protocols and development, S1900E, which is our study of AMG 510, which Dr. Pata and Dr. Gerber will be presenting to you shortly. This is a biomarker-driven study specifically for patients with non-squamous non-small cell lung cancer. Their tumors target KRAS G12C, and they are assigned to different cohorts based on their co-mutation status with respect to TP53 mutations, STK11 mutations, and other mutations. This is currently under central IRB review, and we anticipate that it will be activated in December 2020, and this will be the next presentation. Before we go to that, there's a sub-study concept which is presently in development, which is S1800D. This is going to be a non-match arm where the study drug is N803, which is an IL-15 superagonist, in combination with pembrolizumab versus standard of care for immune checkpoint inhibitor refractory disease. And with that, I think that's the last slide for me. I'm going to hand it over to Dr. Pata and Dr. Gerber.
Hi, everybody. Thank you so much for your time this morning. Thanks, Dr. Wakar, for that introduction to LungMap. So for the next 20 minutes or so, I'll be going through the S1900E training. Sorry, can everyone mute? I'm hearing a little bit of feedback. Thank you so much. So this is a phase 2 study of AMG 510 or sotorasib. It's been recently given a name in participants with previously treated stage 4 or recurrent KRAS G12C mutated non-squamous non-small cell lung cancer. As you heard, both myself and Dr. Gerber are chairs of this study, and I will be representing both of us today. We are very excited as this is hopefully going to activate as early as mid-December. Next slide. So in terms of the agenda, I'll briefly review the AMG 510 drug and, of course, the disease of KRAS G12C mutated non-small cell lung cancer. And then we'll go into the details of the components of the protocol on a high level. Next slide. So AMG 510 or sotorasib is a first-in-class KRAS G12C inhibitor. As we heard from Dr. Herbst earlier on this call, KRAS G12C mutations are found in 13% of lung cancers, but they're also found in 3% of colorectal cancer and appendiceal cancer, and then an additional 1 to 3% of a variety of other solid tumors. AMG 510 mechanism of action includes specifically and irreversibly inhibiting KRAS G12C by locking it in its inactive GDP-bound state. Next slide. So this is data of AMG 510 in patients with KRAS G12C non-small cell lung cancer. This was just a New England Journal of Medicine article published in September of this year. And here we're looking at the waterfall plot of a total of 59 patients with non-small cell lung cancer. Based on this waterfall plot, we can see that the objective response rate with this drug is 32.2%. The disease control rate is very high at 88.1%, and with a median follow-up time of almost 12 months, the median duration of response is almost 11 months. So this is across all dose levels of the phase 1 study. So you can see all the way from 180 milligrams to the recommended phase 2 dose of 960 milligrams. And what we can see is in the patients with treated at the 960 milligram dose, the response rate and disease control rate was very similar. Next slide. This is a progression-free survival of AMG 510 in patients with KRAS G12C non-small cell lung cancer. The median progression-free survival is 6.3 months. It is important to note that these patients were heavily pretreated, so upwards of 80% of patients had received 2 or more lines of prior treatment. Next slide. What do we know about sotorasib toxicity? So in the trial that I just presented to you, there were no dose-limiting toxicities. There are also no treatment-related adverse events that resulted in death. However, the most common toxicities that were seen in the study were GI-related. So there was diarrhea, nausea, vomiting, and abdominal pain that occurred in upwards of 15% of patients of any grade. However, the proportion of grade 3 or greater toxicities were relatively low. With regards to laboratory toxicities, it is important to note that this drug can cause liver function test abnormalities in terms of AST and ALT increases. So it'll be important that we will be monitoring these laboratory studies for patients on this study. Next slide. So KRAS mutated non-small cell lung cancer is really emerging as a heterogeneous and very diverse disease based on the presence of co-occurring mutations that we've now been able to detect because of technologies related to enhanced next-generation sequencing assays. And what we know is that KRAS mutations can co-occur with a variety of other mutations, oftentimes in tumor suppressor genes or downstream effectors. The most common co-occurring mutations with KRAS occur in P53, STK11, and KEAP1. And you can see on the table on the right a variety of retrospective cohort studies from institutions, including Stanford, that show the prevalence rates of these co-mutations. So P53 ranging anywhere from 31 to 42%, STK11 from 20 to 29%, and KEAP1 anywhere from 13 to 24%. And we've learned a lot about these different co-mutation subsets of KRAS mutated lung cancer preclinically and also clinically. Preclinically, there have been noticed differences in signaling and immune features, whether they are immune-active tumors or immune-inert tumors, and then also with regards to metabolic programming, such as whether the tumor relies on glutamine for its energy. In the clinical setting, we've also noticed that these co-mutations may be prognostic in terms of having different implication on a patient's survival with a variety of treatments, and even potentially predictive, where some of these co-mutations may enrich for response to certain therapies such as immunotherapy. So this is a whole new side of KRAS that's been emerging in the last few years. Next slide. So based on this data about the diversity of KRAS mutated lung cancer and also these very exciting KRAS G12C inhibitors such as AMG 510 sotorasib, we designed the S1900 sub-study to answer the question how these drugs work across these different KRAS G12C co-mutation subsets. So in brief, with regards to the eligibility, Patients in the study have to have recurrent or metastatic KRAS G12C mutated non-squamous non-small cell lung cancer, received at least one prior therapy, and have no uncontrolled brain metastases. Based on the biomarker selection from the lung map pre-screening, patients will be enrolled into one of three biomarker studies. The first is KRAS G12C co-occurring with a P53 mutation. We will enroll up to 40 patients in this cohort. The second is KRAS G12C co-occurring with the STK11 mutation, where we will enroll 25 patients in this cohort. And finally, there's a catch-all bucket for patients that don't fit into the first two cohorts, which includes dual co-mutations in STK11P53, and also mutations occurring in the NFE2L2 KEAP1 axis. And the goal accrual here will be also 40 patients. Each of these cohorts will receive standard dosing of AMG 510 at 960 milligrams daily, and treatment will continue until disease progression or intolerability. During the treatment itself, the clinic visits and labs are only every 3 weeks in accordance with the beginning of a cycle, and imaging is performed every 6 weeks for the first year, and then decreases to every 12 weeks in the second year. At the time of progression, there is a liquid biopsy to determine mechanisms of resistance. Next slide. The primary objective of this study is to evaluate the objective response rate, confirm complete or partial responses of AMG 510 in participants with KRAS G12C mutated non-squamous non-small cell lung cancer, and that response will be evaluated individually in each of the cohorts that I've just described. Next slide. The secondary objectives include investigator-assessed progression-free survival in each of these cohorts, overall survival in each of these cohorts, and finally duration of response for those patients who respond within each cohort. We will also evaluate the frequency and severity of toxicity within the full study population. Next slide. So now let's move on to eligibility, now that I've been through the overview of the schema. So as regards to disease-related eligibility, biomarker eligibility for S1900E is first and foremost based on identification of a KRAS G12C mutation, and that is going to be performed on tumor specimens using the Lung Map Foundation 1 assay. As I mentioned previously, patients have to have confirmed stage 4 or recurrent non-squamous non-small cell lung cancer. The caveat to that is that we do allow for mixed histology non-small cell lung cancer as long as the squamous component is less than 50%. The patient's performance status should be 0 to 1, and there has to be evidence of measurable disease by RECIST 1.1 documented on CT or MRI within 20 days of sub-study registration. Next slide. With regards to prior or concurrent therapy, patients have to have received at least one line of systemic treatment for stage 4 recurrent non-small cell lung cancer. There is no limit on prior lines of therapy. There must be progression following the most recent line of systemic treatment, and patients must have recovered to less than or equal to grade 1 from side effects of prior therapy. Of course, there's exceptions for any toxicity that is deemed to be permanent, such as cisplatin-related neurotoxicity or an endocrinopathy that was a result of immunotherapy toxicity. On the table on the right, you can see washouts prior to sub-study registration for the variety of treatments mentioned. Next slide. With regards to CNS-related eligibility on this sub-study, brain imaging, either CT or brain MRI, must be performed within 42 days. Patients with spinal cord compression or brain metastases must have received local treatment and remain clinically controlled and asymptomatic. There's a washout of 7 days for stereotactic radiation and 14 days for whole brain radiation. There must not be evidence of residual neurologic dysfunction unless no further recovery is expected, and on stable or weaning doses of steroids. With regards to leptomeningeal disease, leptomeningeal disease is not permitted unless it is deemed asymptomatic by the investigator and is only detected on radiographic imaging, meaning not present on cytology from cerebral spinal fluid sampling. Next slide. With regards to clinical and laboratory eligibility, we tried to make the prior malignancy criteria very liberal. So it's written as such, no prior or concurrent malignancy whose natural history or treatment has the potential to interfere with the safety or efficacy assessments of the investigational regimen. If patient has a history of known HIV, they must be receiving antiretroviral therapy and have an undetectable viral load within 6 months. And then, of course, since this is an oral drug, no significant GI disorders, and also no significant cardiac disease, not pregnant or nursing, and then very standard criteria for blood counts, renal function, liver function. Next slide. Let's go into the details of the treatment regimen. So AMG 510 is 960 milligrams oral daily dosing. It's important to note that these are 120 milligram tablets, so patients will be taking 8 tablets per daily dose. The dose should be taken once a day as close to the same time as each day as possible. Usually within a 2-hour window of the scheduled time is acceptable. It should not be taken more than 2 hours earlier of the scheduled time, and then the dose should be skipped if 6 hours have passed from the scheduled time. It may be taken without or with food, and if a patient is on a proton pump inhibitor that is medically necessary, such as omeprazole or pantoprazole, then AMG 510 should be taken with food. Again, a cycle in the study is defined as 21 days, regardless of dose delays, and patients will be filling in a diary throughout the study. Next slide. With regards to precautions as related to the treatment regimen, as I mentioned, there is some drug interaction with proton pump inhibitors. So these can actually decrease the concentrations of AMG 510. That's why it's preferred that they're avoided throughout the study. On the other hand, H2 receptor antagonists such as famotidine, if necessary, are permitted, but they should be taken at least 10 hours before and or 2 hours after AMG 510. And then because of drug interactions with AMG 510, there are other specific precautions. So we should avoid narrow therapeutic index medications that are sensitive to CYP3A4 substrates and or transport proteins or PGP substrates. And this is because AMG 510 not only causes in vitro inhibition of CYP3A4, but it can also cause induction of CYP3A4. So we also would want to avoid strong CYP3A4 inducers and certain fruits that interact with CYP3A4 metabolism, including grapefruit and several oranges. Next slide. With regards to supportive care should be given as indicated for care of the patient's side effects or disease-related symptoms as they come up on study. One important thing I do want to point out is palliative radiotherapy for painful metastases is permitted, for example, bone or subcutaneous fat. There is a specific caveat to this, that there should be no target lesions that are encompassed in this palliative radiation, and the patient should not have evidence of disease progression. Next slide. So these are the variety of dose modifications of AMG 510 for toxicity. As I mentioned before, the full dose is 960 milligrams oral daily. The first dose reduction is 480 milligrams, and the second dose reduction is 240 milligrams. We will be using NCI-CTCA version 5 for this S1900E substudy. There is a maximum of 2 dose reductions allowed. And if there are, of course, multiple treatment-related toxicities occurring at the same time, dose modifications will be based on the toxicity requiring the most significant dose modification. Next slide. So what is the criteria for a patient discontinuing protocol treatment? The first is progression of disease or symptomatic deterioration. However, there is an exception built into the protocol if there is clinical benefit per the treating investigator, and the patient is not exposed to unreasonable risk. And what does this mean? This means that at the time of disease progression determined radiographically, there's absence of symptoms and signs indicating clinically significant progressive disease, there's no evidence of decline in performance status, and there's absence of rapid disease progression or threat to vital organs or critical anatomical sites such as near an airway or invading a major blood vessel. If a patient does decide to continue treatment post-progression, if the investigator determines that they are deriving clinical benefit, they will sign a consent addendum for post-progression treatment. Now, if a second progression event occurs, you should let myself or David know, and we can discuss if the patient should really continue on treatment thereafter. Next slide. Additional treatment discontinuation criteria include unacceptable toxicity, a treatment delay for treatment-related toxicity greater than 28 days, a treatment delay for unforeseen circumstances unrelated to treatment toxicity, like if a patient goes in for hospitalization unrelated, greater than 42 days, and then, of course, patients may withdraw protocol treatment at any time for any reason. Next slide. So this is a study calendar, and I know it's very busy, but essentially it's actually quite simple in the sense that patients will be coming in every 3 weeks for clinic visits and very basic labs. And as I mentioned before, the disease assessments will occur every 6 weeks for systemic disease for the first year, and then every 12 weeks thereafter, after year 1. And then I just highlighted in the red box here just to let you know about some of the correlative studies that we are performing with this S1900E sub-study, including circulating tumor DNA is a very important biomarker that we're looking into. And then, of course, there will be additional research consent for Buffy code and plasma biobanking. So I just wanted you to be aware of that. Next slide. So I want to briefly touch on the statistics and primary endpoint, which was really driven by Dr. Mary Redman. So cohort 1 and cohort 3 will have a target accrual of 40 patients, while cohort 2 will have a target accrual of 25 patients. And the reason that is because the estimated percentage of the study population is the lowest for cohort 2, or the STK11 population of just 18%. So that's why the sample size is a little bit lower in this particular cohort. This is a two-stage study. So for cohort 1 and cohort 3, we would like to see 3 responses out of 20 patients before moving on to a total of 40 patients. We expect accrual time for this cohort to take somewhere between 1 to 2 years. For patients in cohort 2, at the 15 patients have been accrued, 2 responses would like to be observed, although there will not be any holding of this accrual to this cohort to a total of 25 patients, and we expect accrual here to be 1.5 to 3 years. Each of these cohorts are designed with a 90% power to rule out a 14% response rate of 5% one-sided type 1 error. The reason we have chosen this 14% response rate is because we looked at a variety of studies that incorporated docetaxel, and this was kind of a middle of the range response for docetaxel, which is anywhere from 0 to 23% with docetaxel and ramucirumab. Next slide. So as Dr. Ernst mentioned earlier, this has been an amazing team effort. I have had a lot of fun designing this sub-study with my co-chair, David Gerber. I'd like to thank Dr. Ernst as the OneMap committee chair, Dr. Ramalingam as the ECOG ECRA and Lung committee chair, and then Mary Redman for all her statistical support, and specific shout out to Mariah Norman, who has just expeditiously move this protocol forward. So thank you so much. And there's so many other people I'd like to thank who are acknowledged on this slide and also not acknowledged on this slide. So now I'm open to questions, and the Lung Map team is open to questions about this sub-study. Thank you so much for your kind attention.
Thanks, Dr. Pata. At this time, you can raise your hand with the hand icon next to your name and enter a question in the chat box. And we'll try to tag team here and take some questions.
Any questions in the chat box just yet? I'm trying to see if anyone has raised their hand. So I have my first question. It's from Margaret, and she asked, I'm assuming Amgen is supplying the drug. And that is correct. Amgen will be supplying the drug. Drs. Pata or Gerber, did you want to comment more on that?
Nope, I think that's it, Emery.
Thank
you. They will
be
supplying the drug.
Any other questions? Please feel free to send in through the chat or feel free to raise your hand. Oh, here's another question from Mildred and Barbara. Is there a plan to allow the use of prior molecular testing to be used for sub-study assignments?
Yeah, I can take that, Emery. So at this time, there is not a plan to allow prior molecular testing for these sub-study assignments. We did have a pretty extensive biomarker call with Foundation Medicine for these biomarker definitions, because some of these biomarker definitions are not as mature as others. So for example, obviously, I think KRAS G12C is quite well established, but we are still learning quite a bit about, what truly is pathogenic for STK11, KEAP1 NFE2L2. So right now, it is restricted to the lung map screening with Foundation Medicine of specifically tumor samples. So this also doesn't include circulating tumor DNA. I can say for us at Stanford, for example, we have an internal next generation sequencing assay that we do use for all of our patients with a new diagnosis of non-squamous non-small cell lung cancer called STAMP. And so that will at least help us with our pre-screening effort for this study. So we're starting to look at our patients to see who may be eligible for this particular study. But again, they will need repeat testing through Foundation Medicine and this protocol. I don't know, does the lung map team, the primary committee, have anything else to add to this commentary with regards to local testing?
I think you said it very well. This has to be confirmed with Foundation Medicine.
Great, thanks.
Any other questions? I'm not seeing any questions in my chat box.
Yes, I see one more question here. What if you use Foundation Medicine CDX for your newly diagnosed and lung patients? Could that be accepted in the future?
I can take that one if you want.
Yeah, I was going to defer that. Yeah, go ahead.
Yeah, hi everybody. Joel Neal here. I'm also one of the chairs. So we are working with Foundation Medicine for patients that have had previous Foundation CDX testing, tissue, not blood. And they're working on their internal system so that we're developing a process so we can use that for eligibility for all of the lung map sub-studies, including this one. As of right now, today, we haven't made that active, but hopefully over the next month or so, we will refine all those processes. So the short answer is yes. Patients will probably need to sign a separate consent saying we will release the results from Foundation to the lung map study when they sign for the lung map consent. So we're working on it. For other testing, though, there are no plans to use other outside testing besides Foundation CDX itself.
Great. Thank you, Dr. Neal. I received a comment back following up from that question and your response that this is great. We use that exclusively for our new lung patients. Any other questions? Please feel free to chat. Use the chat box. When is this study anticipated to open?
Yes, the study is anticipated to open mid-December, so right around the corner.
Thank you. Mariah, I don't have any. Sorry, I was going to say I don't have any questions at this moment, or any new questions at this moment.
Thanks, Amreen. I don't see any on my side either. If any questions come up, we will have a study distribution list that includes the study chairs. It will be S1900E medical query at SWOG.org. So you can reach out there or reach out to me, and I can send that to the appropriate person. All right. Thank you, Dr. Pata.
Thanks so much.
Okay. And with that, I think we can go to the next slide. Now we'll hear from our data coordinators, Louise Heileman and Leah Everhart, with some pointers on lung map logistics, including step 0 ctDNA and specimen requirements and submissions.
Hi, everyone. Thanks for being here. This is Louise. I'm one of the data coordinators for this study, along with my colleague Leah. So as Mariah said, I'm just going to go over some frequently asked questions and some logistics tips about a few different parts of the study. I'm going to start with the screening step 0, or what we call pre-registration step 0, because this is a step we get a lot of questions on. So next slide. Here's a visual depiction of the difference between those patients that need to be registered to step 0 and those that don't. So if you start on the right-hand side, these are the patients that have adequate archival tissue available upon initial review. And those patients can be registered directly to the step 1 registration, and then their tissue is submitted to Foundation Medicine for the on-study biomarker testing. However, if you look on the left-hand side, those are the patients that do not have adequate archival tissue available upon that initial review. And those patients need to have a biopsy done in order to obtain tissue for the study. When a patient has a biopsy done for the study, it is also required that a whole blood specimen is collected for ctDNA analysis and shipped. And this ctDNA specimen needs to be collected within 7 days of the biopsy, because the purpose is to compare the results between the tissue testing and the blood testing. So because of that, you will need to obtain a patient ID number that you can use for the ctDNA collection, labeling the tubes, and logging it in the SWOG specimen tracking system. And that blood has to be shipped out within 24 hours of collection. And you likely will need to ship that out before you are ready to actually register the patient to the formal step 1 registration. For that reason, we created the step 0 pre-registration to obtain a patient ID number. Once the biopsy is done and the tissue has been processed and assessed for adequacy, then the patient is evaluated for eligibility and registered to step 1. At that point, you want to use the same patient ID number that you obtained in step 0 and register the patient to step 1 and then submit the tissue for on-study testing. All right, next slide. So I wrote out some FAQs. Sorry for a little bit of wordy slides, but I hope that these are a good resource you can come back to in the future. And they sort of go over what I just talked about. So step 0, why does it exist? The purpose of step 0 is just administrative in order to obtain that patient ID number so that you can label, log, and ship the whole blood specimen that is required for patients undergoing a new biopsy. And the reason we even need this step 0 is because you will likely need to submit that whole blood before the tissue specimen has been evaluated for adequacy. All right, next slide. So in what cases do I need to register a patient to step 0? Basically, any time that a biopsy is being done to obtain tissue for the lung map study after the patient has consented to lung map and before they've been registered to step 1. And this is what we consider a new biopsy, and that's basically in contrast to submitting archival tissue. Step 0 is not required for all lung map patients. As the diagram showed, patients with adequate archival tissue can be registered and should be registered directly to step 1. Next slide. There are no eligibility requirements for lung map step 0 as it's only an administrative step. The eligibility criteria in section 5 of the lung map protocol must be met prior to registering the patient to step 1. And the next question is whether you can submit a tissue specimen under the step 0 registration. The answer to that is no. The patient has to be registered to step 1 before the tissue specimen can be logged and shipped. This is sort of related to the previous question because all the eligibility is assessed for step 1, and the tissue is the real purpose of the step 1 screening registration. So if the patient has only been registered to step 0, you will not see a tissue specimen available in SWOG specimen tracking. You'll only see that whole blood specimen. And that if you run into that scenario, it's a reminder that you might need to go back. You might have not yet registered the patient to step 1. Okay, next slide.
Sorry, Louise, that's not the next slide, right? I went too far. Apologies. Is this it?
That's the one after this?
Okay.
Okay, perfect. Thank you.
Sure, no problem.
So if the patient is registered to step 0 and then assessed for eligibility, is found to be eligible and will go into step 1, should I use the same patient ID number? Yes, you want to use the patient ID number provided from the step 0 registration. When you register the patient in open, you'll select previous patient and then fill in the demography information using that prior patient ID number. And if you run into any questions with that, definitely reach out so we can help. Okay, in the next question, we have a scenario where the patient was registered directly to step 1, but it's later determined a new biopsy is needed. Do we need to go back and do the step 0 registration? In that case, no, there's no need to do the step 0 registration once the patient has a patient ID number through the step 1 registration. Again, that step 0 is really just to get a patient ID number. So there's no need to go back and do it. You can actually log both the blood and the tissue under step 1 if you need to. All right, next slide. All right, so that's the end of the FAQs about step 0. Again, if you have more questions, we can take them later or feel free to reach out by email. I'm just going to briefly go over the lung map tissue requirements. I know you've probably seen this many times, but since it is such a critical part of the study, we just like to do a little refresher. Next slide. So the tissue requirements for that step 1 registration for the screening step of the study are a formalin-fixed paraffin-embedded block or 12 to 20 slides plus an H&E stained slide. Tissue block is preferred. We do accept fine needle aspirates as long as cell blocks are established, and tissue can be from any site, primary or metastatic, except for bone. If you're sending slides, then a minimum of 12 unstained slides plus an additional H&E stained slide are required, or you can add an extra unstained slide if you don't have that H&E slide. We do recommend 20 slides in order to make sure there's enough tumor content. Next slide. So this is really the critical information in that big blue box. There has to be at least 20% of tumor cells and at least 0.2 cubic millimeters of tumor volume. And those are the two criteria that the local pathologist must confirm and sign off on the LungMap local pathology review form. There's a note that for liver specimens, it's recommended to have a higher tumor content in order to ensure sufficient DNA. Next slide. This is the LungMap tissue specification sheet there, that image on the right. Just like to remind everyone that it exists and it can be a useful resource to provide to your pathology department. It has the information I went over as well as some additional tips to ensure an adequate tissue specimen is selected for the study. And you can get this on the CTSU website or by emailing us here at lungmapquestion@crab.org. All right, next slide. I'm now going to turn over the presentation to my colleague Leah, and she's going to go over some tips and reminders for using the specimen tracking system and actually shipping out your specimen.
Thank you, Louise. Next slide, please. First, I'm going to discuss logging specimens in our production database. It's very important that these specimens are logged in production versus the test database. You can tell that a specimen or that you're logged into the test website if there's a big green block at the top of the specimen tracking page as displayed below. Any specimens that are logged in the test site won't be recognized by our system, and the lab won't be able to verify that it was received once they log in on their end. Another way to tell that a specimen has already been logged into the test database is the packing list that is generated will have the red text highlighted below explaining that it was logged in the test database only and not in our production system. If this happens, make sure that you log out of the test system and log into the production database and relog the specimen. And make sure that the packing list that generates doesn't have that red text at the top. Sometimes you can tell right after logging into the test database, there will be a statement that says you have logged into the test database. Would you like to log into the production database? And there'll be a link that will take you into that login page. And if you're ever unsure whether you've logged a specimen correctly, please don't hesitate to reach out to us at lungmapquestion@crab.org or give us a call. We're always happy to help. Next slide, please. Something else to look out for when logging specimens is to make sure the specimen-specific questions are answered correctly and match the specimen. This will help avoid processing delays when it's received by the lab. And these entry errors can be corrected the same way as specimen entry errors if the specimen hasn't been marked as shipped yet, we'll discuss that later. Some common errors that we've noticed that can create processing delays include date of birth, gender, and local specimen ID number. So please ensure those are correctly entered when logging the specimen. Next slide, please. So how do you correct a data entry error after a specimen has been logged? If the specimen hasn't been marked as shipped, you can delete the incorrect entry and then log it under the correct entry and produce the packing list and ship it from there. Be sure to include the correct packing list with the shipment instead of the one with the incorrect entry. If the specimen has already been marked as shipped, you will need to have the entry deleted by emailing technicalquestion@crab.org and then enter it under the correct entry. Again, make sure that the correct packing list is included with the shipment. If this error is detected after the specimen has already been shipped, please email us at lungmapquestion@crab.org or give us a call so that we can make the receiving lab aware and we'll advise you on how we can correct the incorrect entry. Next slide, please. Next, we want to talk about preparing specimens for shipment. As Louise discussed, with the whole blood ctDNA specimen, the kit is ordered from Foundation Medicine, and it already has a label affixed with the identifiers necessary for them to process the specimen. In order to avoid delays in processing, make sure that the correct identifiers are entered onto that label. The most common identifier we find missing from the label is the specimen ID, which the identifiers are located on the packing list on the last page under label information. So that takes the guesswork out of it, and then you just know you can enter that information directly on the label and not have to search the packing list for it. And again, make sure the packing list is included with the shipment so that the lab can correlate that to the specimen. Next slide. With the step 1 tissue submission, make sure the associated pathology report is included with the shipment. That correlates to the specimen being submitted. And make sure a copy of the local pathology review form is included as well. That's been completed and signed by the reviewing pathologist. But make sure you also keep a copy or the original at your site as well. And again, the packing list. It's also important to make sure that the local specimen ID number matches across the pathology report, packing list, and specimen, so the lab can match them all up and as long as those all match, there shouldn't be processing delays. Next slide. We want to discuss some common mistakes when submitting tissue in step 1. Other than a single stained H&E slide, we cannot accept stained slides. If you submit slides, it's required that at least 12 unstained slides be submitted. But like I said, one stained H&E slide can be submitted. And it's important that the specimen submitted has been obtained from a single biopsy, and multiple biopsies cannot be combined to fulfill the tissue requirements. A single biopsy needs to meet the requirements on its own. Also, we advise against submitting multiple specimens, even if they all meet the requirements. It's best that you select one, and the one with the highest tumor purity, and not submit multiple specimens in the same shipment. Next slide, please. All right, thank you for your time, everyone, and I'm going to turn it over to Jessica Donovan.
Thank you, Leah. Louise and Leah, we do have 2 questions I was hoping you can answer quickly. The first question is, will the study pay for expenses, admission, treatment if patient has a pneumothorax with a steady step 0 biopsy?
Okay, this is Louise. I don't know that I am the best person to answer that question. I'm not aware that we do have reimbursement for that. The reimbursement is a one-time reimbursement for the procedure, and that can be seen on the funding sheet. I don't know if anyone else wants to address that question as well.
Yeah, I would say, this is Mary Redmond. I would just say, Mariah could probably say it better, but there is a set amount for reimbursement on the biopsy, and additional costs are not covered as part of the study. And then there was a question about the database that Leah and Louise were discussing with specimen tracking system, which is distinct from Medidata Rave for entering data. I don't know if you want to answer that more fully than that.
Yeah, I was just going to say that the database we're talking about is the SWOG specimen tracking system. If you have done any other SWOG study, you might be familiar with it. If not, then there is a link directly in the protocol or on CTSU. You log in with your CTEP-IM login information, and then there are instructions that are useful once you're in the system, but you can also reach out to us with any questions.
Thank you, Louise, and thank you, Dr. Redmond. That was the second question about the separate database. I do have one more before we let Jess start her section, and that is, can you confirm that if slides are submitted, they should be 4 to 5 micron sections on positive charged slides?
Emery, could you go back to the slide about the tissue specifications?
Just let me know where to stop. Is this it?
Yeah, I think I can read that. They should be charged and unbaked 4 to 5 micron slides. Yes, that is correct. That's from that specification sheet. So thanks for your question.
Awesome, thank you. So I think we will let Jess take over her section here.
So my name is Jessica O'Donovan. I'm chair of the Lung Map Site Coordinators Committee. Some of you might have reached out to us previously. We are a resource for people who have questions at the coordinators level. So please always know that you can reach out to us with any type of, regulatory, questions of how to, work with the site level. So I'm going to be talking about participating in Lung Map during the COVID-19 pandemic and some tips and tricks of how best to handle and organize and what to do as the coordinator during this time. Next slide. So I want to start out by discussing kind of what it's looked like from my side of what research has looked like during this pandemic. We have had reduced time in the office, fewer team members available at a time, whether people are being pulled to work on specific COVID trials, COVID treatments, whether they be PIs, coordinators, nurses, everybody's being pulled in many directions. There's people who are working from home full time. It definitely makes things more difficult and, definitely more difficult to coordinate care for these patients that are on these trials. It's definitely leading to deviations from the standard protocol, and it's definitely leading to changes in the way that the trial is being conducted. So my little section of this presentation is going to be ways that we can try to avoid as many deviations as possible and, how to potentially conduct the trial a little easier and maybe make things a little better on the coordination end. Next slide. So what can we do? This is a brief overview of what I'm going to talk about. So first off, we're going to work together. We're going to stay connected. This involves mostly team meetings, which I know people are probably quite burned out by meeting, Zoom, WebEx. I know we're probably all tired of that by now, but it is vitally important to make sure that we're all staying in touch. We want to stay organized. This is calendars, checklists, tracking deviations. Planning accordingly. Always know what's happening. Always know what needs to be done with the patients and within the protocol. And then I have in bold here checking in with the protocol. Lung Map, I know that they've sent out memos, keeping everybody updated about what needs to happen, what's allowable per the trial, and what can and cannot be done, and how we should be tracking all of that. And then I'm going to go a little more into remote consenting. So who can remote consent? What are the rules for remote consenting? And then we're going to talk a little bit about remote monitoring, which I'm not sure how many people have experienced this as of yet, but it can be a little challenging. So I just want to discuss that. And then also specimen collection. When is it okay to miss samples, or how to possibly, avoid it as much as possible? Next slide. So meetings. Again, like I said, we're all tired of them, but here we are. For the coordinators, you want to meet to go over schedules. You want to make sure you know who's going to be in the office, who's available to meet with patients, what's going to happen over the next week, who's coming in. as far as coordinators who's coming in, what PIs are going to be available, what nursing staff's going to be available. Are you going to be able to get a hold of somebody in pathology? Are you going to be able to have people to draw the labs that you need? And also what patients are going to be there. And make sure that you're fully up to date on what these patients need. Like, at what point are they in the trial? Because I know at our site we have, like, there's patients that I've had on lung map trial that have been on for years and years that I've been working with, but there's people from my site that need to cover for me now because I can't always be there for one reason or another. So we need to make sure that everybody's up to date on what is happening. And then we tend to meet at the end of the week also to go over what happened so everybody's up to date and kept informed so we all know where everybody stands. And then you also can do, which we do, research team meetings. This is to update everyone, the larger team, so including pathology, pharmacy, nurses, the PIs. This is to make sure that everybody is always aware of everything that is happening, because if you're not keeping the team informed, that's where things start falling through the cracks. That's where deviations that shouldn't be happening start happening, and they're easily avoidable mistakes a lot of the time. Next. So this is just an example. For the next few slides, I'm just going to show some examples. This is what we have started. We do shared calendars. So the study team has this shared calendar, so we always know what's going on. Everybody is keeping in touch. I wake up in the morning, I look at this calendar. If I'm going into the office, I know what's happening. I know which patients are coming in. It's all de-identified by patient ID number. So I know who's coming in. I know what I'm covering. I know what meetings I need to attend that day. And I know throughout the week what exactly I need to be doing and also where my teammates stand and also who's not going to be available and who will be available. Next. So here's another really important thing. We have created checklists. I can't take full credit for how nice these checklists look. This is actually one of my teammates who created these checklists. But these checklists, as you can see, it says what date the patient was consented, confirming who did the consenting, when HIPAAs happened, when samples were collected, what a study assignment the patient ended up on. And it's a really good way to make sure you always know where everybody is at. And again, you know where the patients are, you know what's been completed, you know what needs to be completed next. And this is just for the screening study. If you go to the next slide, this is another example of a S1900E checklist. So this is how you can make sure that a history and physical was done, the vitals, weight and height, performance status. It's really important to make sure that all of this is happening because if the patient's present, you can verify and make sure that you're not missing things just because maybe you're not used to covering this study. Maybe this is the first time you're covering a patient on this study because the person who normally does it isn't available. So this is a very simplified way to make sure that everything is being done. Next slide. And this is what our S1800 study sheet looks like. We have a place where you can put dates of when physicals and lab tests and everything were completed for the pre-study, so you can go through and make sure that everything's within date range for eligibility criteria because, it's not completely unrealistic that somebody who is doing the eligibility and registering the patient might not have been the person who made sure that the labs were collected and made sure that the physical was done. So making sure that everything stays consistent and that everybody's in contact and making sure that everything gets done and avoiding deviations. That's the big message I'm going to have here is to avoid the deviations if they can be avoided, even though I know that it is hard during this time to make sure that that happens. Next. Again, more worksheets. I know our site likes to do these. So these are my lab worksheets. Again, documenting when the additional optional labs were done, whether it was for screening or what week it was for, the subject ID and initials, what the collection date and time were, the process time, what type of sample it was, the specimen ID number. So this also helps with some of the issues that they just mentioned in the previous section about if somebody comes back to you with a question about, which specimen was this, what number was it, you could easily go back into these sheets and say, oh, okay, so the ctDNA was collected on this patient on this date, here's what the specimen number was, and it just makes it a little easier to keep track of when everything was done, what the shipping number was done, when everything was completed. And also something very important that we've added there recently was the open funding completion line, because there is a time limit now of when you can complete that open funding request to make sure that you're getting paid for these samples. So make sure that you're doing that and make sure you document when you did it so you know that it was completed. Next. So here's an important line, which I think I've said kind of and covered already, but you need to make sure that you're checking out the protocol and also keeping in contact with your local institution about what is being allowed. I know at the start of, I'm in Connecticut, so a lot of the start of all of this pandemic, there were very strict rules about what was allowed to happen at our site back in March, April. And we had very strict local institution guidelines we had to follow. So you always want to make sure that you're in contact with your local IRBs and, whoever you fall under to make sure that you're following their rules and guidelines about what research is allowed to be done. I know our site, they were allowing us to treat patients and bring new patients in that need to be treated, but there was other studies that may not have been treatment-based that we were not allowed to complete at that time. So make sure that, you're operating within local guidelines, but also within what the protocol is saying. So it's important to make sure you're following up with all the memos and making sure that you're following your local institution guidelines at all times and make sure you're verifying it and make sure that you're documenting everything. Next. All right, so now we're going to talk about remote consenting a little bit. And I actually pulled up this document to kind of guide me through as we discuss it so I don't misspeak, because I do not want anybody getting the wrong information about remote consenting procedures. So I know sites are using remote consenting for situations such as not wanting to bring in a patient for extra visits that might not be essentially necessary for reduced contact in the hospital. Why bring them in for potential more exposure when they don't have to be, when we can bring them in for a physical and all of that, and then just do the consenting from a distance to just limit the number of times they're coming to the hospital. So important things to remember when you're remote consenting. The copies of the consent form, there needs to be 2 sent, and they need to be sent prior to your discussion so that the person you're consenting has it in hand before you consent. They need 2 copies so that they have one to keep themselves and they have one to sign and send back. The investigator or whoever is consenting must have the regular discussion that they would have when they were, as if you were sitting in the office. It can be over the phone, it can be if you're video conferencing, whatever your institution allows, but it needs to be done just as if they were sitting in the office, like no cutting corners, nothing like that. Exactly documented and everything as if they were done in person. So something that's a little different, there must be a witness present for the discussion. The witness can be on either end of the discussion. It can be on the patient's end. I think we prefer to have the witness on our end. The key is that they need to be able to hear both sides of the conversation. So they need to be able to hear what you're telling the patient and what the patient is telling you. So in some situations, local institutions will require that witness signs the consent form, but that might not always be necessary. But just make sure that everybody's on a conference line or everything so the whole entire discussion is heard by everybody. So once the team receives the consent form in the mail by fax, however they may be receiving it, the investigator or whoever consented will sign on the date that they receive it. And everything should be documented, discussed, in the medical record saying that you discussed the consent form, that everything has happened, that they have signed, that you have received it. And again, if there is a witness, they should sign it. if that's required by your local institution. And the date that they sign must be the date that the consent form was received, not the date that the discussion happened. And then the final informed consent document must be filed away in the regulatory files or in your patient files just as normal. And again, really important, even though the patient has signed it, all steps of that procedure must be completed prior to starting any research intervention. So even though, the patient may email the consent form to you, and you end up having the patient come in, but you still haven't received the consent in hand, that patient cannot start research interventions until you have that consent form. You have that consent form signed by the investigator. You have it filed away. It cannot start until all of those steps are completed. And this document is actually available on the CIRB homepage, the NCI CIRB homepage. So make sure you're reading that carefully before you proceed with remote consenting, because it's a lot more than just having a conversation over the phone with the patient. Next. So for remote monitoring and auditing, previously we might have thought that monitoring and auditing was difficult, but I do see that remote is making it a little more difficult from what I'm hearing from sites. It's important to know that they're still going to request all of the same documents. You're still going to be having to share your regulatory, your patient information, all the pharmacy review. All of these tasks still need to be completed, whether or not they're coming to your site, which is probably not going to be likely for a while. So there's different options. There can be screen sharing through like a secure site, but it's a little more difficult than that. There can be access given to the auditors by access to the EMR by auditors. That also can have some difficulties. A lot of sites currently are doing uploads through the source document portal, which again can have some difficulty because everything needs to be de-identified, and that means de-identifying a lot of documents. And there's not many options for how you can group everything together. So there's like a treatment packet, so you have to upload all the treatment documents for one patient and put them in there and then upload it. So it's a little more complicated this way for sure. Pharmacy review, you have to send all of the accountability documents ahead of time. I know there's some talk about having to show that you have a secured pharmacy. So they're working on ways to make that more easy and available. And you're still expected to do a post-review conference, which can be done with the PI and the coordinator present. And honestly, for what you should expect it to take longer. I know in the past when I was doing monitoring or auditing, I would prepare for a couple of days ahead of time, just making sure that everything was available and ready and put together and like in a spot so that it would be ready for them and getting them a desk that they could sit at. But now we're talking about pulling documents, redacting them, copying, uploading. It definitely took me a lot longer now than it has in the past. So everybody should be prepared for that. This is not a prepare the day before event anymore. Next. So sample collection. So this kind of falls under what we've been talking already. When can they be delayed? When can samples be skipped? It really comes down to what your institution policies are, whether the patients are coming in for visits still. But you should always try to collect these samples if at all possible. There are ways to avoid missing these samples. And if you're communicating and you're staying on top of it and you have people in the office, then it is possible to make sure that all of these samples are collected. But if a patient comes in and refuses, obviously that's per standard. You're not going to have them collected for the optional samples. But like I said, if the patient is coming in for treatment, you can ask you can potentially ask your nursing who's administering the drugs to potentially grab those samples for you if it's possible. But it should be tried to avoid missing these. And with some organization and for preparation, it can be avoided. And if you don't have staff on site, I should say, to get the samples sent out, then there might be an alternative path or issue that you have to look into, try to work through. And I believe that's the last slide for me. Next. Yes. All right, thank you.
Thanks, Jess. Next, we'll hear from Dr. Mary Redman, our lead biostatistician, who will give us an overview of publications.
Thank you, Mariah. Go ahead and move to the next slide. So as was shown earlier in this presentation by Dr. Wakar, we have completed all of the 1400 series sub-studies, and we're happy to report on the number of publications that we have for our S1400 series. The first I'd like to share is that we have a paper summarizing the first 5 years of LungMap, the S1400 series studies, and the screening protocol that not only has been accepted by Lancet Oncology, but is in fact going to be published tomorrow. And so we hope all of you look for that, and we'll be supplying us a link to how one could potentially get to that information. But I think that it just shows what a major effort we've completed to date on this trial. In terms of the biomarker-driven sub-studies, the S1400B, C, D studies have all been published in the Journal of Thoracic Oncology, and we're also excited to report that S1400G, which evaluated talazoparib in homologous recombinant repair deficiency positive patients, has been accepted at Clinical Lung Cancer, and we expected that to be published soon. Additionally, S1400K, which evaluated Taliso-V in CMET positive patients, that study was led by Dr. Wakar, has been accepted for publication in Clinical Lung Cancer, and we anticipate that to be published soon. On the non-match side, S1400A, which evaluated durvalumab in immunotherapy naive patients, has also been accepted for publication in Clinical Lung Cancer. Our anticipation is that A, G, and K will all come out at about the same time, and we'll make certain to let everybody know when those are out. The study evaluating nivolumab and ipilimumab in comparison to nivolumab in immunotherapy naive patients is almost ready to be submitted to a journal for publication. We're anticipating that to be submitted by the end of this month, which isn't that far away. And so we will, of course, keep everyone apprised of that, but that study is quite interesting. It was presented at ASCO year before last. And then finally, the study evaluating durvalumab combined with tremelimumab in immunotherapy relapsed and refractory patients completed accrual about 6 months ago, and we are looking at writing up the paper and summarizing those results very soon. So the study team has been quite productive, and I think that we're showing the benefits of LungMap overall with all of our publications. Could proceed to the next slide. In addition, we have a series of translational medicine studies, which Dr. Cosino is going to describe more fully, but we've submitted 3 abstracts to the World Conference on Lung Cancer in 2021. We've done one on looking at the next generation sequencing data from the 1400 series. We've done one looking at the next-gen sequencing biomarker analysis in immunotherapy-treated patients, so that's specifically patients enrolled on S1400A and S1400I. And then we've done one looking at the next-gen sequencing data comparing tissue to blood for those patients who submitted to fresh tissue biopsies on LungMap. And you can see here that the first paper or presentation is to be led by David Cosino, the second to be led by Dr. Fred Hirsch, and then the third to be led by Dr. Phil Mack. And Dr. Cosino will provide a lot more detail on that in just a second. So next slide. And here he is.
Great. Thank you so much, Mary. So I thought given the lateness of the hour, I'll focus on some of the highlights of our Translational Medicine and Scientific Leadership Committee. I've been serving starting this year as the chair of this committee with really these main goals. To bring together expertise in translational medicine, to assist in biomarker selection and definitions, and sample collection decisions for the sub-studies that are under development in LungMap, to review proposals for prospective and retrospective translational research, and to assist in analysis and publication of sequencing and other correlative science data. We're composed of representatives throughout the LungMap team, including the individuals listed on this slide. A strong representation from the excellent SWOGCancerResearch group, as well as members from FNIH, and then representatives from FMI and Nationwide and the Biobank as listed here. Next slide, please. And we have members that represent broad areas of expertise across types of therapeutics that are heavily featured in LungMap, including immuno-oncology, targeted therapies, DNA repair, and anti-angiogenic therapy. We also have constituents who are fully involved in biospecimen banking and processing, in pathology, and in clinical genomics. Next slide, please. And so the purpose really of translational medicine as applies to LungMap is to utilize this very rich source of patient specimens that are gathered on the LungMap clinical trials to identify biomarkers with the potential to improve patient outcomes by helping guide treatment decisions that are based on specified laboratory criteria. And of note, translational medicine ideas may be proposed by multiple stakeholders, and those include the study chairs of the various sub-studies and of the LungMap team as a whole, the companies who are involved, and also LungMap collaborators, including Foundation Medicine. Next slide, please. And so just thinking about translational medicine in general and what the keys for successful research would be, I think it's evidence that it's important to be knowledgeable about the biology underlying each of the investigational agents. And in an area that I hope we can be helpful in, to be thoughtful about prospective biospecimen collection. If you don't collect the right specimens or process them the right way, a valuable opportunity would be forever lost. So, areas that our committee could help think through for these studies include the specimen types that could be collected, time points for optimal investigation, the quantity that would be ideal for downstream applications, and then the intricacies for processing, shipment, and storage of these samples. And it's important along the way to engage collaborators that could include biologists, biostatisticians, and pathologists. Next slide, please. And so we did, for this specific study, the S1900E study, take a look, for example, at biomarker definitions for KRAS and also the co-occurring mutations, including TP53, STK11, TEAP1, NFE2L2, and COL3. And so it gives an example of this. I'm not going to repeat that since we covered that well earlier. But I'd also like to follow up what Mary mentioned, in that we did submit 3 abstracts to the World Conference on Lung Cancer. I'm very happy to report that over the past couple of days, got notification that all 3 were selected for mini oral presentations at that meeting. Importantly, 2 of the abstracts feature analyses of the earlier SWOG S1400 next-generation sequencing data on 1672 tumors that were profiled on the Foundation 1T5 research platform, which sequenced the exons and or introns of 313 cancer-related genes. A somewhat different set than the current screening platform, but with many overlaps. And quite interestingly, the 3rd abstract featured a comparison of alterations that were detected in the LungMap tumor samples versus plasma circulating tumor or ctDNA. As mentioned earlier today, work on the circulating tumor DNA was of particular note for the S1900E study. Next slide, please. So I'd be more than happy to discuss in greater detail any of these three abstracts. But just to get a flavor for the kind of insights that we can gain from these translational medicine studies, I thought I'd just give a couple highlights for each abstract. First, the one taking a look at NGS data from S1400 as a whole. We particularly focused on the identification of mutated genes that were rarely found together, otherwise known as mutually exclusive genes, and those genes that were commonly found together, otherwise known as co-occurring. And this is quite a bit of interest because it can provide insights into the biology of lung cancer. For example, you may find that certain genes are never found mutated together because they participate in a similar pathway, such as KEAP1 and NFE2L2. So it could be because a cancer only needs a mutation in one of them to disrupt the whole pathway. There are other notions that are currently under investigation, such as that there is a certain amount of alteration that could be beneficial to a cancer cell, but too much alteration could in fact be detrimental. And so there's sort of a sweet spot like Goldilocks in how much alteration a cancer would want to have. And so an understanding of why certain genes are found in combination or never together can be of note, and some of this is featured in this work we'll be presenting at this meeting. Secondly, also quite interestingly, Fred Hirsch took a look at the data from the two studies that Mary mentioned, S1400I and A, because those were immunotherapy studies, and noted an increasingly recognized phenomenon that NGS can be used, including the NGS done on the lung map using the Foundation One platform, to determine tumor mutational burden. And of note, a high level of tumor mutational burden may predict improved survival outcomes in patients treated with immunotherapy. And then finally, the third abstract, looking at a comparison between NGS in ctDNA, so therefore in plasma, and compare that to tissue, showed a rather good high concordance between these two sources of data. And that really does support the use of ctDNA, basically blood tests, for enrollment onto lung map sub-studies. So it's an area of very much interest. Certainly tissue has been the gold standard for looking for alterations that could then suggest targeted therapy approaches. However, blood tests would certainly be a nice way to identify alterations as well, and especially those that can manifest over the course of a patient's clinical treatment. Next slide, please. I think that takes us then to the end of this little bit on translational medicine, but I'd be more than delighted to discuss any of the above with you anytime.
Thank you, Dr. Casanel. Yeah, I was just going to say at this time, if you have any questions, please enter them in the chat box and we can read them off for the team to respond. I know we're running a little bit over, but we're able to stay on for any questions.
Mariah, I have a couple of questions that came in. This question isn't related to the current presentation. However, I'm hoping it can be addressed. We have ordered ctDNA kits from FMI 10 days ago and still have not received the kits. Is there a delay at FMI on getting kits shipped out?
Hi, this is Louise. Yeah, I put this in the chat as well, but if anyone is experiencing this, please do send us an email at lungmapquestion@crab.org, and I will make sure to flag our partners at FMI. I'm not aware of a delay, so it may have gotten, your request may have gotten missed somehow, so I definitely want to make sure we get you those kits.
Thank you, Louise. I don't see any other questions at the moment.
Okay, I see another question here. Where can we get the worksheets that the coordinator mentions? This sounds like it might be referring to the tissue specification worksheet or the site, or is it the site coordinator's worksheet? Might need a little more clarification. Site coordinator.
I'm guessing those are what Jess showed during her presentation. Jess, I don't know if you want to comment on whether you would be willing to share those or not.
I'm not sure if Jess is still on, but we can check in with her and we can help provide those for you. Any examples?
Yeah, so those were examples Jess was sharing from her site. You could also email the Lung Map Site Coordinators Committee and ask for if they would be willing to share, and I think you will get a good response from them. I think we have that email address at the end of the presentation.
Any other questions?
Mariah, I don't see any on my end.
Okay. If you want to go to the next slide, Amreen, I think we can wrap up. I know we're a little bit over here. So thank you, everyone, for all your questions today. Here are the different contact emails where you can contact us for different types of questions. Please don't hesitate to reach out to us. And the Lung Map Site Coordinators Committee is that first email there where you can ask about example worksheets that Jess presented. Okay, and next slide. I think that's it. Yep. Well, thank you everyone for joining us, especially during this unique, challenging time. We really appreciate your support on the trial. Again, a memo will be distributed once the slides and the recording from the webinar are available on SWOG and CTSU, so you can share those with your colleagues who weren't able to attend today. Are there any last remarks from the study chairs or the study team before we adjourn?
It doesn't look like Dr. Herbst is still on, but I'll just speak on behalf of him and all the other study chairs. This is Mary Redmond, that we really appreciate all of you who are able to attend today and your continued support of Lung Map. Thank you.
Couldn't have said it better myself. Thanks, Mary.
All right. Thanks, everyone. Have a great week.
Thank you.
Bye.